then it is such an honor. I'm starting again because it is really such an honor to introduce Professor Karen Spruyt that will speak to you about the sleep disordered breathing and if they have a negative impact on the child development. Yes, no, baby. And though we have a little idea of the answer to this question, but that's really also the profile of the lecturer that is wonderful there that we are having the chance to have here in France. Karen Spruyt is coming from Belgium. Like I will soon introduce you because we were making a pre-record with Karen, so you will maybe see myself repeating a little bit. But Karen is really having a wonderful resume. She was working all over the world. She was making psychology. She was making neurology. She's working since such a long time on the children's sleep disorders and the children development. It's one of the most scientific lectures that I was ever seeing. And that's why it was very important for us to have her speaking here today at the Froggydays. So welcome, Karen, and thank you so much to be there with us. So you are Professor Dr. Karen Spruyt that is now working for INSERM. You were studying at the University of Bristol in Belgium before working at the University of Chicago, the Downtown University in China, and finally being there with us in France. We are very glad to have you in our country at the INSERM, first in Lyon, now in Paris working there. And I am now letting you or starting your presentation and we see each other in 30 minutes, I think. Okay. Thank you very much.
Thank you for, I would like to first start with the thank you to Dr. Fellus for the invitation to present and to this wonderful team who makes this, FroggyMouth team who makes this presentation possible. And so my talk for today will be on sleep disordered breathing and the impact of sleep disordered breathing on the development of a child. So my first slide presents the outline, which is, I start with the discussion on a brief introduction on sleep and explain why it's so important in development of a child. Next, I will focus on sleep disordered breathing and particularly the spectrum of sleep disordered breathing. And in the second part, I will discuss studies, a summary of studies examining the impact of sleep disordered breathing on health, cognition, sensory motor functioning, as well as socio-emotional and behavioral functioning of a child. So at the end of my talk, I will give you some concluding remarks. So let's start. So sleep is defined based on the brain waves as well as the eye movements, the muscular tone and cardiorespiratory functioning. And based on these parameters, we will divide sleep into the stage 1, stage 2, stage 3 sleep, as well as the REM sleep. And the stage 1, 2, and 3 combined form the non-REM sleep. The non-REM sleep characterized by slow eye movements, reduced muscle tone, slow and steady breathing. And then you see the REM sleep, which is paradoxical because this sleep has rapid eye movements as well as an absent muscle tone and very fast and irregular cardiorespiratory functioning. So this is the adult sleep structure combining the non-REM stage 1, stage 2, stage 3 deep sleep as well as the REM sleep. But when we are born, these components are not really developed as we know in an adult sleep structure. So the newborn has active sleep, which is the precursor of REM sleep, and the non-active white sleep is actually the precursor of the non-REM sleep. And this image already shows how sleep develops in the first couple of weeks as well as months. And so if you look at 15 weeks, you see that there the black lines become more consolidated to the night period. So the black lines represent sleep, the white lines represent a wake period. And so after the 15 weeks, it becomes more structured, that sleep consolidates to the nighttime period, whereas the wake consolidates or stays with the daytime period. You also see on the right side of that image that there's about 62% of time that the infant spends to sleep around these 15 weeks. So it shows that during these first weeks, first months, a lot is changing in the sleep of the child. And so these elements of the adult sleep structure start to surface. And you see in the first couple of weeks, you see in months, you see that the stage 1 characteristics are 1.5 to 3 months really start to show up in this electroencephalogram, the EEG, where we measure the brain waves with. That around 9 weeks, we start to see these spindles, sleep spindles, show that there are thalamocortical connections from the brainstem to the cortex, and as well as towards the end of the 6 months, we see these K complexes, the vertex waves, which show that this brain is developing, maturing, and sleep shows more and more the characteristics of the adult sleep cycle and sleep structure. Around these 6, 7 months, you start to see this deep sleep at the stage 3, as well as the REM sleep. So this structure develops, establishes itself throughout the first couple of weeks, months, first years of life. And that is very important to realize that these characteristics are linked to the development of the child. And this is also an overview slide, which shows that this proportion of sleep that we spend as a neonate versus as an adult or an elderly person, that the proportion of REM and non-REM sleep develops, evolves, and matures throughout our lifespan. And so it shows as a neonate that we spend 50% in non-REM and REM sleep. But this slide also shows that as a childhood period, we have really this decrease in the REM sleep, where the non-REM sleep, the deep sleep, remains throughout that very formative period of a child's development. So what we also see is that throughout the development of that child, that in the first couple of years, the daytime napping will disappear, and that will help in reducing our REM sleep. And what we also see is that the sleep pressure will change. So as a neonate, you have, as the one slide showed with the black and the white lines, that you have an increased sleep pressure. So a short period of wakefulness will be followed with a period of sleep, because that homeostatic, that drive towards sleep, that drive for the brain to further develop, to further mature. And so that changes throughout the childhood period, as shown on the image on top. So these characteristics are very important to keep in mind on how the sleep matures, how the sleep develops, and how this can be linked to the development of a child, the daytime behavior that we see. And so sleep problems or poor sleep is a very common concern of caregivers. Such that the numbers shown on this slide indicated already that a child with a typical development, about 20 to 30% of them will experience a sleep problem, a complaint that will be expressed by the parent. And these prevalence rates are way much higher for children with an atypical development. On the other hand, the child does not outgrow, or not all children outgrow their sleep problems. As you can see, about 30 to 40% in typically developing children, the sleep problem persists into adolescence all the way to adulthood. And again, in those children with an atypical development or with disabilities, those prevalence rates are much higher. So in these last couple of years, there's increasingly more studies showing that poor sleep, whatever way we define it, is adversely impacting the development of a child. So I think we can conclude that sleep is the most forgotten, most overlooked behavior of this century. This brings me with this introduction of sleep to a specific sleep problem, a very common sleep problem, being sleep disordered breathing. And so sleep disordered breathing, the core element here is control of ventilation. And so the brainstem receives information from chemoreceptors, the motor inputs, such as the movements of our chest and our abdomen, and behavioral input. For example, when you dive into the swimming pool, you can hold your breath before diving. So your brainstem integrates this information to come to this coordinated respiration, so the rhythm of our breathing. And so this is very important because our tissue needs the right balance between oxygen and carbon dioxide. And this balance is very important for the tissue. And if there is any difficulties in this coordination of respiration, then we might talk about difficulties such as obstructive sleep apnea or apnea, which is an absence of this airflow. But you see the chest, the abdomen still making these breathing movements. So you see an ongoing respiratory effort, but there's upper airway is obstructed. So a difficulty of an obstructed breathing process. The central apnea is where you also have this absence of airflow, but you have the absence of effort. So there's the absence of this effort with no airway obstruction. So the mixed apnea has a combination of the obstructive and the central apnea. So you see the breathing trying to continue with and without these movements of chest and abdomen. And then you have the periodic breathing, which is really a couple of apneas that we have that occur in a succession to come to a periodic type of breathing. So these are examples of obstructed of apnea, of stopping or difficulties in the control of the ventilation. So what is then this sleep disordered breathing and specifically the sleep disordered breathing spectrum? Well, it goes from primary snoring all the way to the Pickwickian syndrome. And so the definitions or the characteristics are with primary snoring that you have that increased effort, but without arousal. So the EEG does not mark these arousals of the cortex. The upper airway resistance syndrome is the one that you have the respiratory effort, but here you see a repetitive respiratory effort, and that is related to arousal. So you really will see arousals on the EEG. The obstructive hypoventilation is one where you have the gas exchange abnormalities, but here you don't have that apnea or hypopnea, whereas with the obstructive sleep apnea syndrome, you really have either a partial or a complete obstruction leading to hypoxia, hypercapnia, and or respiratory arousals. And then the Pickwickian syndrome is one related to obesity. So throughout the spectrum, you see the degree of airway obstruction that will make that your ventilation, that your breathing is more and more difficult or perturbed. So that's what we call the spectrum of sleep disordered breathing. So the most common indicator that has been used and is very commonly, it's the indicator of sleep disordered breathing, and that is the apnea-hypopnea index developed or created by Christian Villeminot, a French person, who used this index and these clinical cutoffs to diagnose sleep disordered breathing and the severity of it. So when for a child it's below 1, it is normal, but as soon as it goes higher, all the way to more than 5, it is severe sleep disordered breathing. But there are other indicators such as the obstructive apnea-hypopnea index, where we count really also the obstructive apneas. You have the central apnea index focusing on those central apneas. You have the respiratory disturbance index, which really looks at the disturbance of the respiration, of the oxygen desaturation index, which counts the drops in saturation while sleeping. So these are elements for diagnosis, but also the clinical features are important in diagnosing sleep disordered breathing. And this goes again from the snoring more than 3 times per night, but it also goes with the gasping or the snorting type of breathing, as well as the observed apneas. It's about having a dry mouth. It's about daytime sleepiness. It's also the problems with enuresis that might occur, ADHD. So those are clinical features that may pop up a red light and where you need to think about sleep disordered breathing. There are also physical symptoms where we need to have an eye on in terms of the adenotonsillectomy, the large adenoids and tonsils that are removed as a treatment for sleep disordered breathing. So those are elements, craniofacial elements that we need to watch for to help us diagnose sleep disordered breathing. In terms of polysomnography, the image shows again different indicators that physicians at a sleep study will record and will help us to determine whether the child has or does not have sleep disordered breathing and the severity of the sleep disordered breathing. And then very common, actually the bulk of studies in literature, sleep literature, use questionnaires, and the most commonly used questionnaires is the one of Spruyt, but also the one from Chervin, Ron Chervin, the sleep-related breathing disorders scale, and then one that I with Dr. Gazal have validated to screen for sleep disordered breathing. There's also the obstructive sleep apnea 18 questions that help you to screen for sleep disordered breathing. Most of these questionnaires use items such as snoring or mouth breathing, as well as difficulty breathing are common items in these questionnaires. So if we express sleep disordered breathing in some numbers, the primary snoring, the prevalence rate is estimated to be 15 to 30%, whereas obstructive sleep apnea is 1 to 5%. So these are rather guesstimates because we still miss large-scale epidemiological studies. And in terms of children that are obese, the prevalence of obstructive sleep apnea is way much higher, it's 36%. So it's quite often or common that children between the age of 2 to 8 years old show this snoring, sleep disordered breathing, because of the morphological aspects, so the growth of these lymphoid tissue, as well as to the size of the pharyngeal area. So it's really craniofacial area that we have to watch out around these 2 age range in this category. There's, in terms of prevalence rates, equal for boys and girls, but indeed there plays a role of family history of snoring, apneas, allergies, exposure to tobacco smoke, prematurity, and as I said, anthropometric characteristics, so the constitution, obesity, as well as the craniofacial features. There's also studies showing some increased risk for those of Asian and as well as Afro-Americans descendants. And I would like to also stress that in those children with developmental disability and mostly genetic syndromes that affect craniofacial aspects, that they haven't reached prevalence rates. Did not ignore this. So sleep disordered breathing, in a summary, we really need to watch out for it. It's not only because the numbers are high, but also for the next part, the impact of sleep disordered breathing on a child's development. So the child comes in for a sleep study. There's lots of electrodes, and the 3 top lines, you see the EEG, you see the channels measuring your brain waves. Then the next one is the chin, the movements of the chin, and then you see breathing parameters, and as well as the bottom one, the saturation. And the red line already shows in stage 2, as you can see, that there is a cessation of this airflow, and you can see that chest and abdomen are still making these movements to continue to breathe. And that's actually what we see on the polysomnography as an obstructive sleep apnea. You can also see on the top the microarousal that occurs, and at the bottom line you see the drops in saturation. So in terms of etiological factors, it is the reduced upper airway patency as well as a collapsibility related to this obstruction, the reduced tone of these upper airways, the anatomical features, as I mentioned, possibly also a nasal obstruction. So some studies show these alternations in resting neuronal metabolites, and especially in the area of the hippocampus and frontal cortex, And for the psychologists, neuropsychologists listening, they will quickly make the link to memory as well as attention and executive functioning when you hear that these areas are suffering when or impacted by sleep disordered breathing. So the pathophysiology, and that is a little bit the billion-dollar question. So which parameter is which influencing or creating the true impact of sleep disordered breathing? Well, you have the repeated episodic arousal, so continuously these arousals from your sleep, which makes your sleep fragmented and creates daytime sleepiness. You have this intermittent hypoxia, so the drops of oxygen that goes to your tissue, which will create this systemic inflammatory changes, vascular changes in the brain. And then you have the hypercapnia, the excess of the carbon dioxide that will create in the muscle tones and a blunted arousal. So all of these come into play, and it's a disruption of your normal ventilation because of these repeated arousals. But it's not only their repetition, it is making the sleep shorter because you continuously have these arousals, but also inefficient, and as a result, you have a poor quality of sleep. And the top reminder says that all your tissues need this well-balanced oxygen in your body, and if that goes wrong after 10 minutes already, and you can create some brain damage. So it's really important to have or to watch an eye for this sleep disordered breathing. But the problem is that for now, we still cannot pinpoint which morbidity, which deficit links to which specific pathophysiological mechanism. So very much more research is needed. So we do know that, and it already showed on the spectrum, that children with sleep disordered breathing, their health will be impacted. And what we see is that they are at an increased risk to develop this cardiometabolic syndrome. The cardiometabolic syndrome, as the slide shows, it's type 2 diabetes and cardiovascular disorders that will create. So for children specifically, we will see a decrease or delayed growth, childhood obesity, we will see inflammatory disorders, cardiovascular consequences, and mostly linked to the intermittent hypoxia and sleep fragmentation, we will have the dysregulation of blood pressure, anatomic functioning, the glucose and lipid metabolism, and so the risk of the inflammation. So it's desaturation, it's arousal, it is the fact that it will be repetitive, that it will be continuously throughout your sleep, and specifically for children during their REM sleep, and not only the repetition of it, but also their duration. And the longer the apnea will last, the worse actually it is for your tissues, for your health. So the problem is way much more complex because, as I mentioned, so you have this fragmented sleep, you have these arousals, you have the daytime somnolence, but we also have this shortened sleep. And if you look at the graph, the red line is the one for the obese children that have already decreased total sleep time. The overweight, the blue line, we also see some changes, particularly in terms of the variability. So you see that these variabilities, particularly sleep variability during the weekend. So on top of having sleep disordered breathing, you have a shift in bedtime. So it compromises this sleep structure that needs to roll out throughout the night in the couple of hours of sleep that the child has. And so this study showed the link with the sleep variability in obese children with their triglycerides, so putting them at an increased risk of this cardiometabolic syndrome. And so more complex because it's not only health, it is also the development, the cognitive development, and that's a little bit the chicken and the egg problem. No? So is it the sleep disordered breathing creating the overweight, the weight issue, or is it the child with overweight problems that will have an increased risk for sleep disordered breathing? So I've done this study modeling the links between the three components, so sleep disordered breathing, weight, and cognition, cognitive ability of the child, to measure, to quantify, the impact of them when one was a mediator in this relationship. So on the top one, you see the weight as a mediator. So we know from the literature that sleep disordered breathing has a negative impact on the cognitive abilities of a child. So what happens if the child becomes obese? So what happens if the weight of the child starts to mediate this already negative relationship? Well, it increases the negative impact of sleep disordered breathing on cognition. The same when we measure or when we start from the child with a weight problem versus, when sleep disordered breathing mediates this relationship. So bottom line is that the negative impact increased about 40 to 50% for the child that is having sleep disordered breathing and or with the weight issues. So this brings me to cognition. So what is then the impact on cognition? Well, there's a couple of studies in the literature, but I've tried to summarize 20 years of literature and only looking at those studies that link or compare children with sleep disordered breathing versus children with typical development. And as you know, psychologists like to put your score in relationship to the population, and the population mostly scores within the green zone of the Gaussian curve. So there are studies that look at obstructive sleep apnea, so sleep disordered breathing, but really specified as obstructive sleep apnea syndrome, whereas there are studies that look at typically developing children versus children with the spectrum of sleep disordered breathing, so including those that snore all the way to the obstructive sleep apnea. So if I summarize those studies, you see here on intellectual performance, so IQ tests, we see that both in the preschoolers as well as the school-age children have a negative impact of obstructive sleep apnea on their intellectual performance, as well on language, as well as on attention and executive functioning, and as well as on memory performance. So overall, they underperform at least one or maybe more standard deviation from a normal typical population. So that is obstructive sleep apnea compared to typical developing children. So when we compare now those with the spectrum to typically developing children, we see that particularly the school-age children, in terms of their intellectual performance, it goes into the wrong direction, so a negative impact on the IQ. Keep in mind, this is the spectrum, so this goes from snoring all the way to really clear obstructive apneas. So in terms of language, the studies are not really clear, and it doesn't really show a huge impact, but it does in terms of attention and executive functioning, particularly for the preschool children, that these studies show that snoring all the way to obstructive sleep apnea will have a negative impact on executive functioning, as well as for memory tasks, it's particularly good for school-age children. So, as we know, the main task of a child, apart from sleeping, is of course learning at school. So these studies showed a poor to average cognitive performance, which will surely have its impact on scholastic performance. And this is a meta-review showing on the side of the graph that it is worse for those with sleep disordered breathing. Sleep disordered breathing defined in terms of a spectrum. So showing that all aspects in school, math, science, all aspects really have a huge impact of the sleep disordered breathing, that they underperform. One standard deviation, two more. And then you have, as teachers, so you look at this cognitive sluggish tempo. It's the child in class that has the mouth breathing, has difficulty in capturing, when you explain something, the things from the first time. So you need a couple of repetitions before they really capture the information that you have given them. If that child has other scholastic problems, a learning problem, or a behavioral problem, it will the impact will be worse. So Sensory motor functioning, we see here that there's too few and inconsistent findings. Very few studies really look at the motor functioning, but again, the ones that compare typically developing children with those at sleep disordered reading spectrum, you see that at school age there are already motor deficits, whereas in terms of visuospatial, so the orientation within a room, that the child, especially school age children with obstructive sleep apnea, will show these problems. So again, too few inconsistent findings, but again, showing that there is some influence. So the diversity in studies are quite difficult, and to make one single concluding remark. Socio-emotional behavior problems. Well, there's a lot of studies, especially in terms of questionnaires that have been used, and they show internalizing as well as externalizing problems. So being problems such as depression, anxiety, somatic complaints, all the way to the typical ADHD complaints of hyperactivity, but also aggression, attention problems. And this is very common also in school age and preschool children. Key is that studies have shown that after the removal of adenoids and tonsils, that this has resolved or partially resolved the behavioral complaints that parents or teachers reported. And please do not forget that children with developmental disabilities who are already at an increased risk of sleep disordered breathing, that they for sure show this irritable behavior or might show aggressiveness. Think about, how the sleep breathing is disrupting their sleep and may have an influence on their daytime functioning. So there's a couple of studies showing how to treat this obstructive sleep apnea, and there was a large clinical trial in the United States called CHAT study, because there's tons of adenotonsillectomies done, and surgery is never without risk. So to see what actually the impact of the sleep disordered breathing was and how this treatment resolved the sleep issues and the behavioral or the cognitive complaints. And then in the last couple of years, there's also the myofunctional therapy that is increasing its number of publications and its support that it does have an impact on apnea-hypopnea index. It does create fewer desaturation, so better oxygen saturation for your tissues, and as well as decreasing of the mouth breathing. But then again, both the CHAT study as well as other treatments, both of these types of studies highlight the importance of the degree of efficacy, and that there are way much more studies needed to come to a very conclusive aspect. So this brings me to the concluding remarks. So can I answer yes, no, or maybe? And so we could do a poll here. So is it yes? I think in terms of health, I've hopefully convinced you this interrelation to obesity and overweight and the chicken and egg problem, but the consequence remains that we have this risk of cardiometabolic syndrome. Do not forget that it's a poor performance, and it's maybe one standard deviation, but if you are that sluggish cognitive tempo and you need more time to absorb what is taught to you during your formative period of childhood, these one standard deviation or more underperformance is not neglectable, I believe. And then you have the improvement of cognitive and behavioral functioning after a treatment. So I think partially we can say yes. On the other hand, partially we should also say no, because we cannot say sleep disordered breathing gives only this and this as a negative outcome. So the most influenced domains or functioning fields of a child is language, memory, attention, executive function, and then more difficult to show it, but some studies do show intellectual performance and for sure the academic performance. So why is it so difficult for us to pinpoint this parameter in the sleep disordered breathing gives this specific outcome, this specific negative impact? Probably because we're dealing with a developing child, probably because brain is plastic and brain is developing. And so the maybes in the literature say that, okay, we have this dose-dependent relationship that needs some careful attention, especially in those that fall in this gray zone, that fall between 1 to 5 as an apnea-hypopnea index, so this dose-dependent relationship. And then something that might have been overlooked in studies is that one part or one component of our functional domains is this information processing, and information processing is present in all kinds of tasks that we do. Even now, when you are listening, you are information processing, and so and it's not a really specific cognitive domain, and they might have blurred some of the results. And so with this, I would like to end my presentation and come to thanking again this wonderful team and a nice frog next to me for this recording, and hope to see you next year. Bye-bye.
Thank you so much, Dr. Spruyt, for this wonderful lecture. It has been such a pleasure to have you there, to welcome you here in the FroggyMouth studio to record this wonderful lecture that I was seeing on the chat is having a lot of success. Unfortunately, Dr. Spruyt is not there in live, so we will have to make the whole question and answer session, as I was already telling you and explaining you, on the Facebook group. Once again, it is called Froggydays Participants e-Congress. Join the group and you comment your question. Karen Spruyt will come to answer you all those questions. And I thank her again because it was such an honor to have her. And I hope that we will soon be working on the little projects that we have to make scientific studies also on the application of FroggyMouth on all the sleep disorders, because that's one of the biggest aspects that we want to develop, us not only as FroggyMouth, but as people that are caring about the myofunctional sciences all over the world and the applications of myofunctional sciences. I think that sleep is also the application of the future of all those sciences based on the wonderful work of Christian Guilleneau that we are once again having a thought about. Thank you, Dr. Spruyt.